And well, to discuss with you the issues in treatment decisions in elderly patients with metastatic soft tissue sarcoma, I would like to focus on that because I'm no surgeon by background, so would like to stick to my own profession. And what I would like to do is just give a bit of an impression about what kind of sarcomas you can expect at this age, discuss some treatments that were given to elderly, and also discuss something about quality of life and how elderly are looking at who should take the decision in well, the difficult decision you face when you have a metastatic disease. And then I think there will be time for discussion, and I see my slides as a kind of well, basic background for this discussion, and I'm happy to have the questions afterwards. So let me see. Elderly population, well, we all know it's a very heterogeneous population. And I think many of us know all the very fit, but also very frail people. And well, people can also become patients. So there's nothing else there than in the general population. You have a big difference in patients who are becoming of age. And when we look at sarcoma patients, in general, I think there's a conception that it's really a disease of young people. And it's interesting when you consider the whole epidemiology of sarcomas. Well, there is no cancer type which covers the age range of 0 to 100, but sarcoma is. But if you look in more detail, then you can see that half of the patients is 60 years or older when diagnosed with a sarcoma. And that are data which we collected from the Netherlands Cancer Registry over the last decade. Well, our German colleagues did the same. And when you look here, you see here from here on, the upper are the male and here are the female. So from here, you can see the incidence of sarcomas. In blue, all sarcomas. In red, soft tissue sarcomas, and in green, the bone. So you see the vast majority is soft tissue sarcoma. But you also see the rise, it's an enormous rise starting from 50 and especially from 65. And the same is applicable to female. And you also see when you are very old, then the incidence drops. Well, so it's also important to realize which histological types we see most in elderly patients. And these data are also based on the analysis we did in the Dutch Cancer Registry. And you see here the majority of subtypes you can see at 65 years and older are liposarcomas, myxofibrosarcoma, the UPS, leiomyosarcoma, spindle cell sarcoma, and angiosarcoma. And that's remarkable because you don't see here what we call the translation patients who have a histology with fusion genes. They are not very common at elderly age. So no Ewing sarcoma, no synovial sarcoma, although a few can still occur, it's very rare. Then it's important to realize that there are only limited data and clinical studies available in the evaluation of elderly soft tissue sarcomas. And well, that's strange because I just mentioned that there are many elderly patients with soft tissue sarcomas, but having them in clinical trials, that's another thing. So, and old age should not per se be considered as a contraindication for the administration of chemotherapy or other systemic treatment or an operation. So it's important to realize that still these patients can be suited for a clinical trial or at least for a treatment. But of course, you have to take into account that they may have comorbidity, prior cancers and treatments, etc. And also it's important to see what the physical and also cognitive function of patients are. So it's important to do pre-treatment assessments, to ask patients' preferences, and we can use special geriatric screening instruments to see how patients who report in the clinic that are very fit for whatever are actually not that fit if you ask them in a good way with such a screening instrument. So Bernd Kasper and Peter Hohenberger had a very nice review in 2020 on these patients, and they looked which particular treatment aspects you need to take into account when you discuss treatments with patients. So you should think about safety and toxicity. Of course, we do it always, but you should realize that the reserve capacity of elderly patients is really less. We all know it, by the way, from COVID. It's not only applicable to cancer. Elderly patients can tolerate disease and treatment less. We also have to look at comorbidities. It may be 1, but it may also be 8. So you can imagine that that may, has an impact on the decisions you can take with the patients. And we have to realize quality of life, which is a mixed bag. And quality of life is about physical functioning, psychosocial functioning, emotional functioning, role functioning. Many aspects can be taken into account and can be discussed with the patient. So in 2013 already, and there was an interesting publication, Annals of Oncology, of patients older than 75. And they were diagnosed with metastatic or unresectable soft tissue sarcomas in French and American centers. So they really went through all the treatments of these patients and the discussions in the clinic. And you see that 62% of these patients received systemic therapy, and they evaluated whether that might differ between their outcome. And you can see here that the patients who only received best supportive care had a much less lengthy survival than those who were on treatment. But there may, of course, have been a reason not to start treatment. But it's important to have these data. And you can also see that patients who received best supportive care, were indeed patients who were older than 80, had a less good performance status and had more comorbidities and had metastatic disease. So deciding upon to start any treatment is really dependent on many factors, and many of you, I think you will recognize from maybe friends or family members in general. So clinical trials in elderly are challenging. Do they measure what is most meaningful? That's a question. Is the study population representative for all elderly, or are we really focusing on the very fit patients? Are the studies done with the optimal and available drugs and not too toxic drugs? Because if you give doxorubicin and ifosfamide, you know, I think everyone will know that's a very toxic drug combination, then maybe it will not end up in a very good situation with the patient because of a lot of toxicity. So what do we know from standard doxorubicin elderly with patients with metastatic disease? That's a question, and I will come back to that. So there's a need for clinical studies in elderly, because if we want to speak about decisions, and that's the title of this talk, we need to have data, of course. And we need to know which disease we can expect. If we expect a patient with a Ewing sarcoma at the age of 70, first of all, we have to realize, is this diagnosis the best one? Is it really proven that this is a Ewing sarcoma? And then think about, well, the normal treatment is, of course, very intensive chemotherapy. What does that mean for this particular patient of 70? And maybe all the data we have is not applicable at all to this patient. So we need to have data, that's what I want to say, that are applicable to the situation of the patient. And then we see, in fact, there's a lack of reference data in elderly. So what we did was at least try to figure out in the EORTC, which has a big database of patients treated in studies with advanced soft tissue sarcoma, And we wanted to focus on data of elderly, and we defined them as 65 years or older. So we went into all the trials. The trials were not done in elderly specific, but we could, of course, define the patients of 65 years and older and see how they did in comparison to the younger patients. So who were the patients who participated in these trials? And we focused on the first-line treatment only in advanced metastatic soft tissue sarcoma, and patients only treated with anthracyclines, which we call doxorubicin and epirubicin, and for today we combine them. Patients treated with ifosfamide or with a combination. And we wanted to know how did they respond to the treatments received. Well, here you see the whole overview of the 13 clinical trials selected, and in total almost 3,500 patients participated with all the regimens and ifosfamide. Well, we don't give any more to currently, so we selected only these 11 trials, then we had 3,000 patients left. And then again, a selection was made. And then all in all, you can see here, we had 2,362 patients younger than 65, and only 10% of the total were older than 65 years. So that's important to note, because I just started this whole talk with that almost half of the patients were 60 or 65 years or older when you are diagnosed with a soft tissue sarcoma. So we here have a selection of patients, 10%, who entered the clinical study. Well, how did they do? Here you see that overall there was no significant difference in the median overall survival, but at least we now have an idea what is the overall survival of patients 75 years and older. And here you see it. Here you can also see the progression-free survival. There's also no significant difference between the groups younger and older than 65 years of age. But you also see that the number of patients, of course, is very low in the end. And with regard of the responses, you will say, well, why would there be a difference? Well, you can consider that the histology may differ when you are older. And here we lumped all the histologies of soft tissue sarcomas together. And you may also think, maybe the histologies at an older age are less responsive to chemotherapy. But all in all, we didn't see a significant difference. And we have to say that almost a third of the patients had progressive disease despite receiving active treatment. So it is important to note, if you explain to a patient when they start treatment, that you are always very honest that also a patient can have treatment and the result can still be progressive disease. So the conclusion that was, although almost half of the patients with soft tissue sarcomas are above 65 years or older, only 11% participated in EORTC first-line clinical trials with standard drugs, no fancy drugs, just the drugs we can give in the clinic. The median age of this group, I didn't show that, but was relatively low, was 68 years. Well, we all know that 65 plus is, of course, a very broad group. And in fact, I think there were only 10% or so, 10 patients of this whole group older than 80 years. So in fact, we don't have data on patients older than 80. The outcome of the elderly group was slightly worse, but not significantly. And we think that the results of this analysis can be used as a benchmark for future trials. So there were other interesting studies, and I won't go into all details, but I think this one is an interesting one. It was published in the Journal of Clinical Oncology in 2020, so that's a very prestigious journal in oncology. And there was a study done by the Germans, led by Victor Grunwald. And there they randomized pazopanib and doxorubicin as first-line treatment in patients with metastatic soft tissue sarcoma at the age of 60 years or older. And as you may know, pazopanib has been registered for second line and beyond, not in first line. We also have to realize that pazopanib is in many countries not available and reimbursed in the first line. But it's interesting that they did this study, of course, to see whether it makes a difference. Pazopanib is an oral anti-angiogenesis inhibitor in the first line, is an oral drug. You have to take it on a daily basis, versus doxorubicin, which is chemotherapy, which we give every 3 weeks. So it's a different situation of treatment. So here you see that pazopanib was given just at the standard dose, as was doxorubicin. And you may expect different toxicities because doxorubicin is chemotherapy, which has the leukopenia, etc. And pazopanib is a drug that can give nausea every day. So not only the first days after the treatment, because you have to take it every day. So there are many differences in toxicity, but it's interesting. So the patients were randomized in a 2-to-1 situation, which means that you have 2 times more the chance to get pazopanib than doxorubicin. And the design was made as a non-inferiority trial. And that's always a bit, difficult in a statistical perspective, in a way that in the end, you may end up in, well, it may be the same, the result, but the statistical power is less than if you do a prospective trial where you compare drug A versus drug B. But this was a non-inferiority trial. So here you see the median age of the patient was 71. And in the end, 81 patients received pazopanib and 39 doxorubicin. The results didn't show a difference in PFS and also not in OS, but they saw a difference in toxicity. But as I told you, these are totally different drugs, so that was not unexpected. But it's important to note that patients who are on pazopanib will not have neutropenia, and that's also important if patients are more vulnerable to infections for whatever reason. If you give pazopanib, then they will not have this vulnerability to infections. And that's also important. On the other hand, they will be more prone to having hypertension in a population that may have already hypertension. So you can, it's an interesting study. I have no time to go into detail, but if you want to read it, I could advise you to do it. Well, they also did a geriatric assessment, and that revealed that only 15% had 2 or more comorbidities. And that's interesting because it means that we still had a pretty fit population here, because the rest had 0 or only 1 comorbidity. And having hypertension, for example, is already a comorbidity. So 2 or more was not seen very often in this trial. So the comments to this trial and also to other trials is, well, PFS was the primary endpoint of this trial, but in fact it's a surrogate endpoint because we think it's an assumption of delayed growth. But will that translate into an improvement outcome in survival or in quality of life? Which means that if you start a treatment and you only have radiological metastatic disease but no symptoms, what does it mean if you have a PFS that's only 4 months, for example? Because if you have no problems, then you have had the treatment which induced toxicity, but maybe you have no benefit at all. This is a concept which you can discuss not only for elderly, but it may be more important for elderly, whether PFS is a good endpoint of a trial. So as stated here, PFS may not translate into a meaningful outcome due to individual preferences, and whether the meaning of PFS is always understood by all patients and even by doctors is questionable. Of course, everyone knows what PFS is, but what it means for a patient in his life, that may be disputable. So integrating objective outcomes with patient-reported outcomes may provide a greater insight into patient-derived benefits of treatment. And if you collect patient-reported outcomes by, for example, questionnaires, it's also important to use the most applicable questionnaire, because if you ask very general questions, you may end up in something that is not really meaningful for the patient sitting in front of you. And an important thing also is that, especially in the past, patient-reported outcomes were collected, for example, through the EORTC Quality of Life Questionnaire C30, but the data were not published. And that's, of course, really awful, because patients were, well, they put time and effort in filling out these questionnaires, but if the data are not published in the end, we don't have the data. So it's also very important nowadays that we publish the data, and in general, not as a second or third publication, but that we mention already the most important PRO data, so on health-related quality of life, often alongside the primary endpoints of the trial. So how to make decisions then in metastatic disease in elderly if we don't have many data? Well, first of all, it's important to realize what matters most for the patients in front of you. Does the patient have symptoms? What is the physical and cognitive function of the patient? Are there comorbidities? Were there previous tumors and treatments? So what is the treatment goal in our discussion? Are we talking about local treatments? Because it's also possible if a patient has pain at a only localized disease, you can also choose to only irradiate that issue, that, for example, metastasis in the vertebra. Do we talk about systemic treatment? Are there clinical studies available, and especially for elderly, or are we only talking about their supportive care? So we wanted to know more about what matters most for patients, and we have run a study which we call the holistic study in metastatics of tissue sarcomas in centers in the UK and in the Netherlands, so specialized sarcoma centers, where we asked patients before they started systemic treatment, so they all started systemic treatment, at least at the moment when they filled in the questionnaires, that was the idea. And we asked about their health-related quality of life at baseline, and also at several time points in the follow-up. And we published about patient preferences of this holistic study last year. Eugenie Younger, who has done a PhD on this study and on other studies on health-related quality of life on metastatics of tissue sarcoma patients, was the first author of this publication. And we asked these patients, as I said, on treatment preferences and also on decisions, how they were involved in decisions and how they would like to be involved in decision taking. In total, 130 patients participated in the trial with an almost equal distribution between the UK and the Netherlands. And the median age of these patients was 62 years. So it's a relatively, but not very young population, as you can see here. And we asked them about a preference for length of life or quality of life. And I walk you through this slide. Here you can see the patients of 18 to 39 years. There were only 11 of those, and they all preferred length of life. So that was very significant. That was only the thing they wanted to have as the most important preference, why to start treatment in this situation. For patients 65 years and older, there was a total different situation. 50% of those preferred quality of life as the most important endpoint, in fact, endpoint of their treatment, and 35% had length of life as most important, and 15% of patients, well, they had an equal distribution between length and quality of life. So this is a very interesting slide and also an important slide. And it's very interesting. I had a patient in my clinic last week of 65 years. I discussed with him at length a clinical study, not in particular for elderly patients, but with a new drug versus doxorubicin. And I gave him 2 days of, he could think about, and then he would make his decision. And he told me after 2 days, I don't want to enter this fancy study. I don't want to have treatment anyway. And I asked him why, and he said, first of all, I don't want any toxicity. And second, I don't want to go to the hospital. And then in the end, he said, if I would have been 40 years of age, I think I would have taken another decision. So this is just an example of our clinic where patients are really making decisions also based on age. So what we also did was asking about their role in decision taking. What is your preferred role? And I come back to that in the next slide. And what was your actual role? So before you went to the clinic, what do you want to have as a preferred role in decision taking, and how did it go when the decision was taken to start a treatment or not? And then you see here that most of the patients would like to have a collaborative decision-taking role. So do it together with the nurse and the doctor you were speaking. And in general, we see that there was not a big difference in actual and preferred role in the treatment decision. So in fact, that was a good sign that there is not a very big difference in what patients want and how it went on in the end. And here you also see, and I will help you because this is a bit busy slide. We asked about the actual role. So were you very active in the decision taking? Was there a collaborative way of decision taking or passive? And sorry, I see now that in the publication, this should have been more on the right. But this is in fact the group with a passive decision taking role. And I would like to focus on active and collaborative where it's significant. And what you can see here is that female patients in general, more than male patients, want to have a collaborative role, and male patients are a bit more passive in the decisions taking in this study. Another interesting thing was that patients in the Netherlands have more a priority for active role taking than in the UK. Why that is, well, you can think about it, but that was in fact an interesting thing when you do clinical studies, that you can compare different populations. And in the end, we also saw that patients who have a worse performance status, and there were only few patients, they were really very preferred an active decision in the decision whether or not to start systemic treatment. So the ECOG status is also very important if a patient is fit or not. So most patients preferred not a passive but active or collaborative role in treatment decisions. I showed you there's a gender, performance status, and country difference, which was significantly different associated with the preferred role. And there was happily a huge concordance between the preferred and actual role in chemotherapy decision taking. So this all led to a new study that will run now soon. Well, it's open in some countries already. And that was based on a call made by the EORTC Quality of Life group. They said, we are keen to fund proposals with a randomized trial where health-related quality of life is part of a primary endpoint. And then we thought, well, we have done now this interesting research. We know that elderly are more, well, they find quality of life more important. Let's consider a study design in elderly patients with metastatic soft tissue sarcoma, because we also have shown that data are lacking in this group in clinical studies, as I showed you. So we see there's a really an unmet need of running a trial in this population. And we want also to have patients' input in the design of the study, and patients were asked to give input, and Roger and others were very willing to do so. So this was the start of a trial which is now the EORTC 1976 soft tissue study. The tolerance study is the acronym. And it's a study developed by the Soft Tissue and Bone Sarcoma group in collaboration with the Quality of Life group and the Elderly Task Force of the EORTC. And we will give, let me see, this is the study design, where we give doxorubicin 60 to 75 milligrams per square meter, so the standard arm. It's a 1-to-2 design, so you have 2 times higher the chance to get doxorubicin in a weekly schedule or oral cyclophosphamide. And if you ask me why have you chosen for this, I will come back to that. Well, doxorubicin is the standard. And long ago, there was also the low-dose doxorubicin monotherapy given to patients with metastatic breast cancer. And actually, that is still given to more vulnerable patients. And we don't know how that, how the efficacy of this monotherapy, where you give this as another schedule with which we expect less toxicity, how that compares in efficacy as compared to doxorubicin 3 weekly. So that was a reason to choose for this monotherapy drug schedule. And another basis for the oral cyclophosphamide was found in the European Journal of Cancer publication of Olivier Meer, where he had given this metronomic schema to patients, to elderly patients, also with metastatic soft tissue sarcoma. So we had literature to design this trial in this way. And we also added at screening a geriatric assessment. And we look at quality of life by an elderly scale. We look at daily living assessment and the EORTC quality of life C30 questionnaire. It's very important that we collect all these quality of life endpoints, because the first endpoint will be physical and role functioning at 12 weeks. So if we don't get the data back from these questionnaires, we will not be able to have our first endpoint. And here you see the entry criteria, which are pretty relaxed, I must say, for patients. So this is the G8 geriatric assessment that has different items about nutrition, weight loss, mobility, neuropsychological problems, body mass index, how many medications a patient takes, and how they fare in comparison with other and the age. And then you can have a total score. And for the entry of this study, patients who have a G8 of 14 or less are eligible for the study, and all patients 70 or older, but we do this geriatric assessment also in the 70 plus, of course, to learn more about what kind of patients enter studies for metastatic soft tissue sarcoma. These are the objectives. The primary objectives is to assess whether a higher quality of life in terms of the disease and the treatment on physical and role functioning is achieved with metronomic schedules of doxorubicin or cyclophosphamide versus standard doxorubicin. And then the second endpoints are other aspects of health-related quality of life, as you can see here. And of course, whether there's a difference in PFS, OS and tumor response, we look at toxicity and tolerability. These are the primary endpoints, as you can see here, and the secondary endpoints. And we will also look at exploratory endpoints like quality of life. Here are again the inclusion criteria. For the sake of time, I will skip this one. Here are the key points of the tolerance study. It is a randomized phase 3 study. The accrual time is expected to be 3.5 years with follow-up time of 2 years, which makes a total duration of 7 years. 185 patients will be necessary for this study. We have 35 sites open in 9 countries and also in countries that are not always participating in our clinical trials. So that's also important. And these drugs are available across the globe. So it's also a study which has impact for not only the high-income countries, but hopefully also middle and who knows, also low-income countries. So there are challenging aspects. It's a new concept. We really need the quality of life questionnaires. You have believers and non-believers, so not all colleagues will enter patient in this study. We need 185 patients, which is still a lot, and no fancy drugs. So some colleagues will say, well, let's do something else. But it is representative for real life setting, we think, and there can always be competing studies in elderly, but still we believe that this study will run. So thank you for your attention, and I'm very happy to receive questions. Here's my email, just in case you want to send me suggestions, comments, or whatever.
Professor van der Graaf, thank you so much. I think we think a lot about the adolescent young adult population and look at how important there are questions there. And you've really outlined how important this other end of the spectrum is as well, and that there are some very important questions, especially given that more than 50% of sarcomas occur in that population. So with that, we've got about 6-7 minutes to take some questions. Are there any questions from the floor or from online? Well, maybe while people are thinking of questions, I wonder, do you have any explanation for your analysis of the EORTC study, where there were 10% of elderly enrolled into the study compared to the incidence being over 50%? Is it a sense that maybe they weren't offered the study, they refused the studies, that didn't meet criteria? What do you think?
Well, that's a very good question, because in fact that's what you want to know. In general, the patients were quite fit with performance status of 0 or 1. So you can already imagine that those with a PS performance status of 2 were not included. I think many of the doctors are hesitating to give these drugs to patients, and there were also randomized trials. So with drugs where you think, I don't want to give them to patients of that age. So I think we don't know it, and it's a very good question. We had a workshop at the EORTC over the last 2 days on what can we learn from real world data. And our surgical colleagues have done a study in retroperitoneal sarcoma, the STRAS study. It's had a question of whether radiotherapy pre-operative would lead to a better overall survival than surgery alone. And well, there was no difference for the whole study. But apart from this STRAS data, they also did observational data. So the patients not entered in the study, but from the same centers where the study was running, collected data. They call it the structured data. And in the end, with these data, they could see that there was a subgroup who could benefit from this pre-op radiotherapy. And the reason that I'm saying this is that I think we learn over time that if we collect observational data from patients who are not in a clinical study, but who are in the hospitals being treated, we can see more who are these patients who were not asked or who were not entered. And that's, I think, a major step forward if we can do that more in clinical trials, if we adhere to the same follow-up and other stringent things that we do in the clinical study context, because then we can answer your question much better. Then we know who are the patients, the 40% who did not participate in all these clinical trials.
That's very, very helpful. Was there a
yeah. Hi, Markus Wartenberg. Hi, Winette. Thank you for joining us, and this was really a fantastic talk. I was really interested in this part about the decision making. So I'm really interested in the weaker part of the treatment when it comes to decision making, but also what about information and communication? So what is your experience with this group of patients? Because very often not the patients contact our patient organizations, are more the daughters or the sons of these patients are contacting our organizations. And speaking just for my own parents, they are 80 and 86, and they are cardiac patients. So they are very well educated, but when it comes to information and communication, they are really, it's terrible. They don't understand anything, more or less, or they believe the doctor without any questions. That's the part of decision making. So my question is more in the direction of information and communication. Do we need to change maybe also the information of these patients, maybe also the style of communication, because you always have these patients in the room when you talk to these patients. Is it more, do you need more time for these patients? So that's my question in the direction of information communication that also leads to decision making.
Well, that's a very good question. Of course, elderly patient is a very mixed bag. And patients, the older they are, the more, well, comorbidities they have still a very passive role in decision taking. Maybe are also not interested at all for the information leaflets we give them, and only want to have a nice doctor who is caring for them. And think all the discussions, please do it with my daughter, who is also in the room, and I trust my daughter. It's a very important thing, and I think a topic for research in itself, because there's not only the age, and the persons who are in the room are very different. Often you see the daughters with their parents. Sometimes you have a patient with a partner who has already dementia. And if they come with the two of them alone, then it's very difficult to know whether the patient really understood everything. And you have patients from a different cultural background. And that's really something I'm also seeing, that patients from other parts of the world also behave in a different way, or not only behave, it's just how they take decisions. They take the decisions for the parents who we even don't know that they will die from the disease. And these are all aspects, and I must really say, are not always taken into account in the whole conversation with elderly patients. And the first and second consultation in a hospital, I think, really needs a lot of time to be convinced that the patients understand the background of the disease, the poor prognosis anyway, and how we can help them in the best possible way. And if there's no time, and the communication is not very well in the language, and that's a very broad definition of the patient, then I think the decision will not be good anyway. It's an important topic for you as SPAEN, I think, to work on as well.
Absolutely. I wanted to ask you, you highlighted that Roger was involved early on in the planning, and I know EORTC is really working towards the engagement of patients. Could you talk a little bit about that experience, and maybe Roger can share as well about how you engaged, what was the input, how that worked?
Well, maybe Roger, you can tell what you have done in this for this trial.
Yeah, thank you, Winette. Thanks, Denise, for that question. My interest in this goes back a long, long way, because I remember in the very early days of doing advocacy, I was rung up one evening by a guy, probably in his 40s, who wanted me to persuade his father that he should take the chemotherapy, which had been offered to him. His father was in his 80s and had decided not to have the chemotherapy. It's for sarcoma, obviously. I had to talk the son out of that argument. I certainly wasn't going to be part of trying to persuade his father to take that treatment. But what I did is I persuaded the son that the best thing he could do was spend more time with his father, take him for walks, enjoy lunch in the pub, play dominoes, all those sorts of things that enhance life. And he went away reluctantly. And I heard from him about 5 months later, 4 or 5 months later, his father had died. And he said he'd had the best 4 months of relationship with his father that he'd ever had. And his father said thank you to him. And I thought that was worth a fortune. Well, to go on a few years, 2013, I was diagnosed with metastatic sarcoma in the lungs. Fortunately, it was spotted early. There were oligometastases. Surgery was possible. But during that period of decision making, with the help of my oncologist at the time, Dr. Mike Leahy, and also with Palmer DeLeo at London, I investigated what all the alternatives were for the treatment for the condition I was in, and which included not having treatment, which, given that surgery was regarded as feasible, but the surgeon didn't want to do surgery immediately, he wanted a second scan in 1 month's time, gave lots of time for thinking. So I investigated all these different opportunities for treatment, from ablative therapies like radiofrequency ablation. Stereotactic radiotherapy was just beginning to appear. Proton therapy wasn't around at that point, but would now be in the equation. All these ideas, and just ran into an absence of data. There was no data on how people reacted and responded to these things. Well, I had my treatment. I had surgery, left lung 1 month, right one the next month, and spent the next couple of months recovering. And then through the avenues that we have with SPAEN and with the National Cancer Research Institute in London and Sarcoma UK, I started raising the question of why are we short of data? I little knew at the time that Winette was already working on this with her team in Amsterdam, and a little later when she spent a couple of years working in London. So her data on the study that you saw from Eugenie Younger was really, really helpful to me, really valuable. And it was about that time that we started talking, Winette and I, in passing conversation about how we took this further, how we got to a study where we could actually generate some really strong data one way or the other. And it was over the course of then about probably close to 2 years that the idea of the 3-arm study came up. We looked at issues such as, could we regard people who did not want to go into a randomization between 2 treatments, be recruited as a third dumb arm, a non-treatment arm, but still contributing data in terms of quality of life to the study. Things like that got discussed and debated. I had no idea what treatments were feasible. Of course, I'm not an oncologist. That's very much for Winette. And as the final protocol or draft protocol began to come together probably about 2 years ago, a bit more than 2 years ago, it really began to feel like a strong study, and one that I wanted to succeed, because we were going down that quality of life reporting direction. So it's been a long journey for me. It's been a slightly shorter journey for this study, but I think it's been a long journey for Winette too, because of her clinical experience. So we sort of came together over a period of time. And I know she's talked to others. I'm not the only person that she's talked to, and I wouldn't expect to be. But I've really appreciated the discussions that we've had.
Thank you for sharing that and for giving us some insight into that. Again, Professor van der Graaf, thank you so much for an excellent talk and bringing to light this important topic.
Thank you, and I answered the chat. Yeah, have a good conference.